I'm going to just go over planning for the end of life patient, and this station is basically you have to write 2 care plans in 14 minutes, and we've got to consider what the main concerns of this patient was when they were admitted. They will have many symptoms, probably due to the condition they're in. So pain, breathlessness, nausea, anxiety and mobility probably being the main concerns. Now, I would choose, personally, I would choose pain and perhaps nausea or breathlessness. So this time I'm going to go over pain and nausea. So pain, we would have got that information from assessment the previous station, and this is now going to be a measurable care plan because you have the number the patient gave you for the pain score, and this can be used in both the problem and the aim. So we're also going to use whereabouts the pain is. So when you're writing the problem, it's best to write which pain you're talking about, because people could have pain in more than one place in their body. So it would be important to say it's chest pain. He's told us in assessment that his pain score was 6 out of 10. So that's quite considerable pain to have to deal with. So we're going to aim for it to be 2 or less out of 10. Yeah, we want to resolve the pain, but being realistic and achievable, I've set the aim for 2 out of 10. So we are acknowledging the patient may be experiencing pain at some point, but we're trying to keep that minimalised. The re-evaluation time and date in the pain care plan should be hourly. Over the years, we've realised from the feedbacks from the test centres, this is what they prefer, hourly. It's important not to leave a patient in pain, and I think by saying hourly, it would force people to look at the care plan, make sure that they've implemented everything and do regular checks on the patient. So we will put hourly for that. The interventions, you can use a Materid again, the mnemonic, to help you pick the interventions. So explain is, we would be expected to explain to the patient all aspects of care and gain consent before writing the care plan. So the care plan should be a shared document that you create with the patient. So that's just our way of saying we have discussed this with the patient and they have given consent. Monitor hourly. So monitor pain score hourly. That's a 0 to 10 pain score using the universal pain scale. Assess the patient, which is David, using the PQRST method, which you've already learnt for the pain assessment scale. You don't need to describe what the PQRST method is. You could just mention it there, and also add, look for non-verbal signs such as guarding, grimacing, withdrawing. Not every patient will offer that they are in pain, so we do need to look out for that as well. Distraction techniques. Now we can teach the patient distraction techniques such as deep breathing, mindful that this patient is probably struggling to breathe, and perhaps, breathing exercises could be discussed with the physiotherapist just to make sure, again, that they are able to do this correctly and get the most out of it. Mindfulness meditation has been identified as an activity that can not only be enjoyable and rewarding, but it can also help with some symptoms such as pain control and nausea and anxiety. So I think this would be a reasonable thing to offer the patient. Administer pain relief. I mean, we would expect to be giving the patient analgesia when they come to hospital. So do mention that on your care plan. But we do need to monitor if it's actually working. So you can add monitor effectiveness hourly. Referring the patient, think about who we could refer this patient to. Obviously, they would have seen the doctor already. but we can include other people to help with the pain, such as members of the multidisciplinary team. We could think about referring to the pain team or the palliative care team. So the pain team deal with chronic unresolved pain once a doctor has tried all other avenues and tried other analgesics. Palliative care team can also look at particular drugs and how they're working for the patient and explore if there's anything else that can be done. So we're going to also remember to inform David, to inform the staff when his pain is increasing. So some patients don't like to ask and don't like to mention that their pain is getting worse, or they hope it'll go away or improve, and quite often when the pain gets stronger it's harder to deal with for them and for us to get the right painkillers. So if we just encourage him to let us know when his pain is starting to get worse. And then as usual, we write at the end of the care plan, document all care as planned. The other care plan that I thought I would have chosen for this patient would be nausea. So I'll go over that one. It's a very common complication of end of life for patients. So I think it would probably be, for me, an important care plan. So David is experiencing nausea due to his condition and medication. And as we've discussed before, nausea is a common symptom and a very troublesome one. So the aim is that David will not experience nausea and he will tolerate sips of fluid. Reevaluation. So this is a bit different to pain because although yes, it is a very bothersome symptom, it's not quite as distressing as being in pain. So I have put the reevaluation time and date as several hours or a few hours from the time stated on the scenario. So if it was, say, 1,500 hours now, they're telling me to write the care plans, I might put 1,800 hours is the time to review him, and that would be today's date. So do include today's date. And although we can check the patient more regularly than the care plan, it's the time we're going to look at the care plan and see if we've achieved what we said we would and if it's working. So again, you'd explain and discuss all aspects of care with the patient and gain consent. We could also talk about how we're going to monitor the episodes of nausea and vomiting. Nausea may have triggers and it may vary for different people. We could make sure that we're monitoring the episodes of nausea and vomiting on a chart, and also being mindful of the triggers that may be contributing to this. Certain smells such as dinner being served or cleaning products, and also just seeing or hearing things can actually trigger nausea, such as seeing certain medical equipment could make somebody become nauseous. And so it can work on different senses. Mobility or activity may be one of the triggers. So we can do that. We can monitor for triggers and make a note of that and try to minimise anything that's causing him to be sick. Timely administration of antiemetics makes quite a big difference in how their experience is, whether they're going to experience no nausea, slight nausea or vomiting. So we do need to emphasise on the care plan to administer the medication as prescribed, which means on time as well. So that's a line that we'll put in our care plan: administer all medications as prescribed and antiemetics as required. So also, again, like pain, encourage the staff to tell if he's suffering with nausea. Teach David to inform staff if symptoms persist. When you've got a patient who is vomiting, it's not very nice to leave bowls of vomit in the room for long for their comfort and dignity, and it's unacceptable really. So We need to make sure that they do have available tissues and vomit bowls, but also the removal of those vomit bowls when they're full. And you might be measuring, I don't know, but you need to remove that. Also mention using the call bell and ensuring that's close to the patient, so they can use the call bell when they do vomit and we can take it out of the room. It's been well documented that relaxation techniques can actually lessen the feelings of nausea, and when used regularly especially, it can help with pain, anxiety, control sleep, sleeplessness, and also a pleasant experience. So there's various ways of achieving this. Visualisation, visualising on something pleasant, imagery work, music, and you could talk to David about the sort of relaxation techniques he would use and include that into the care plan. Teach David how to use relaxation techniques using visualisation, imagery or music. So position also can alter how they experience their pain. Lying down exacerbates nausea sometimes, and lying flat means the gastric juices are going to rise up into the esophagus and increase the feelings of nausea. Sometimes just walking and moving can make the nausea worse. So we need to be mindful of how much exercise he can tolerate and his position in the chair and in the bed, and make sure that he's sitting in a reclining position. An upright reclining position would be ideal. So David will require regular oral care, including brushing teeth, and may require mouthwash as well. Offer as much assistance as is required, but we could instruct David to brush his teeth twice daily, but this is also a patient's choice. But you could explain to the patient previously at some point that this could reduce the chances of infections and tooth decay. So, and also make it a bit more pleasant for them if they've had vomiting episodes. Mouthwash as required as well. I think we've covered everything now in the pain and the nausea care plan and how to lay them out. I just thought I might go into a bit more depth in case you were wondering why some of the things are included in there, and hopefully to try and help you commit it to memory. But practicing regularly and just thinking about how a patient is affected by these things, and how we could improve their quality of life. Hope this has been helpful.